Hi everyone. So today we will present our signature assignment on AHRQ case study, Knowing is Not Enough, presented by Tessina, Kathy, and Stella. This particular case was submitted by Dr. Paul Batelden from Dartmouth Medical School. He is the professor of pediatrics and of community and family medicine. So first I will present the case description and then what went wrong. A healthy 57-year-old man underwent a liver donation procedure. He began to manifest some tachycardia late on the second post-operative day. Early on the third post-operative day, he began to hiccup and complained of being nauseated. Later that day, he was pronounced dead. So on this slide, we will look at the sequence of events and what went wrong. On January 10th, patient undergoes surgery to remove the right lobe of his liver. No complications occurred during the procedure. January 11th, patient is recovering. His condition is stable. On January 12th, patient is so-called examined during rounds by first-year transplant fellow and PGY4 surgical resident. Transplant fellow neither looks at nor asks for patient's vital signs. At 4 p.m., patient develops tachycardia. So what went wrong on January 12th? We don't see anywhere the presence of primary surgeon. So primary surgeon being inaccessible to perform post-operative patient shows lack of expert support. Also failure to perform adequate post-operative evaluation by first-year transplant fellow and PGY4. Both shows failure to examine, failure to diagnose in a timely manner, and treat in a timely manner as well. Since residents did not perform adequate post-operative evaluation, um, we are sure that there is lack of documentation by the residents, which contributed to the difficulty to follow up care, because it's vital for physicians to be aware of the symptoms and patterns that a patient has been experiencing, and this information can best gathered only by completing the medical history and the thorough exam, which this scenario lacks. Also, lack of interpersonal communication skills of the nurses, as well as the knowledge and experience to identify and report tachycardia in a timely manner. On January 13th, around 1 p.m., patient develops hiccup and nausea. Patient is given medication to control symptoms, which may have masked the underlying problem. Here we see due to lack of expert support, we see failure to order any tests to rule out any possible abnormalities. At 8:45 a.m., patient is examined by PGY4 resident who is unaware of the patient's continuing tachycardia, nausea, and previous hiccup, and writes a progress note indicating vital signs are stable. So here we see an ineffective handoffs, which contributed to gaps in patient care and eventually breaches in patient safety. We all know that change of shift report is crucial. This ineffective or insufficient reporting may have laid the foundation for failure to diagnose and treat in a timely manner in this case. And then at 1:10 p.m., patient vomits brownish materials, tachycardia persists. PGY1 surgical resident calls transplant fellow who is in a bookstore outside the hospital. He advises against insertion of an NG tube. Upon returning to the hospital and despite the patient's distress, he does not examine him, but instead prepares a preoperative workup on another patient scheduled for surgery the next day. So the transplant fellow being inaccessible to the patient to follow up at this point, um, definitely below the standard of care. Also, for patient, lack of expert support to provide proper care. And then at 2 p.m., patient's oxygen saturation is unacceptably low. 100% oxygen is administered by mask. 3 p.m., nurse calls PGY1 resident to inform her that the patient is continuing to vomit and has difficulty breathing. Here, we don't see any communication between nurse and resident until 3 p.m. We don't see any additional order or referral from PGY1 resident, which proves lack of expert support to provide proper care of the patient during this emergency situation. And then at 3:10 p.m., patient becomes unconscious after vomiting more brownish material and blood. Code is called. Resuscitation measures are unsuccessful, and then at 3:40 p.m., patient is pronounced dead. Besides the sequence of these previous events that I discussed, the hospital's transplant unit was inadequately staffed. Investigation report found that one first-year surgical resident who had started on the transplant service only 12 days before January 13th was left alone for 3 hours on January 13th, the day of the patient's death, to care for all 34 patients. So these are the sequence of events and what went wrong. Next, my teammate Kathy will discuss about how can the issues be resolved.
Thank you, Christina. I'll take it from here. Hi, my name is Kathy, and we're going to look at how the issues can be resolved and who and what role do other disciplines have in resolving the issues. These are a few of the areas where we saw errors. Communication failed, inadequate assessments of the patient by both the RN and MD, and pass-offs that were not correct. They were not using proper medical equipment. The staffing patterns were not appropriate for that area. And there was no attempt to activate the chain of command to get any type of help. Did they think about calling the surgeon that did the surgery? Or did they get the house supervisor involved? Let's take a look at the transplant fellow's actions. He left one resident to cover 34 patients. He left the hospital to a nearby bookstore. When called by the resident surgeon, he did not want an NG2 put in, but he didn't give any advice either. When he did come back to the hospital, he ended up seeing another patient, evaluating them for the surgery the next day, and he never went in and saw this patient. Those are the actions that we saw. I mean, for what he went through, who knows? Safety culture is a must for employees to feel they will be protected and they will be safe. There was not a just culture or a safety culture on this unit. Now let's take a look at medical negligence. It's defined as an act or omission, failure to act by a medical professional that deviates from the accepted medical standard of care. This is the criteria for being medically negligent. Was there a failure to act? Was there an act of omission? Or did they deviate from accepted medical standard of care? These are some of the events that happened on that day. His heart rate got up to 160. He was vomiting blood. He had hiccups off and on. His blood pressure was dropping. And due to the staffing and the unit being so overwhelmed, they weren't able to do anything about it. They possibly could have called the surgeon that did the surgery, called the house supervisor for help, or even their unit manager if they weren't there. Just a bad situation for all of them. The fact that he had hiccups was significant. If it would have been passed along, I'm sure he would have gone back to surgery. Hiccups are triggered by the phrenic nerve, and with the bleeding into his abdomen, he was putting pressure on it, and it irritated it enough to cause the hiccups. These are the areas of improvement that we found. They need to adopt a culture of safety. The nurses, the residents, and the surgeons need to learn how to effectively communicate, including SBAR for pass-offs. They need to take a good look at the policies and procedures, and if they need to be renewed or updated. They need to determine if there was truly a knowledge deficit there, and if so, set up training to cover it. And they need to look seriously at the staffing patterns. What roles do other disciplinaries have in resolving these issues? Well, administration needs to play a big part, especially in the relationship between the residents and the physicians. Never should there be 34 patients to one resident. Nursing's going to have to look at staffing patterns and get those to where they're appropriate. And administration needs to commit to having the staffing levels where they need to be. The policies and procedures are going to need to be evaluated and changed if needed. I will be passing this along to Stella now, and she will finish the presentation.
So what would be the solution to the problem? I think closing the unit for 1 month will be a better choice to disinfect the surgical unit and also to give enough time for staff to be allocated appropriately, because we might need to hire more doctors or nurses or nurse practitioners, and also probably add another resident on board with a little experience in the transplant procedure. We can also implement a post-op day 2 follow-up with internal medicine, especially in this case, we had a patient with increased heart rate. I'm sure the internal medicine could have upgraded the care to telemetry or DOU or ICU. The surgeon must see the patient daily. This can be one of the implementation we have to change. The surgeon that performs the surgery, and also if they cannot do that, there should be a surgeon who can round on behalf of the original surgeon who performed the surgery. The resident doctor must not be left unattended at any given time, and they should also be given the access to the surgeon at all times. There are so many barriers towards implementing this solution. Funding will be one of the issues. We will need money to hire people. to restructure the staffing for the surgical unit. And also we have to deal with management. It might be a problem to get them to accept and approve of the changes that should be made. And also it will be time consuming to try to hire new staff for us to cover the staffing that we need to cover for all the patients. Hiring new employees will be also another issue we have to think about, and we have to go through the proper channels to hire people on this unit. All of these things will actually need to be approved, and it might not happen. That can be a problem. There can be also communication barriers depending on how we present this problem to the management for approval. Finally, this is our visual plan for the change. I have a picture of our surgical unit. This is like the entry part of the surgical unit when the people are getting ready in PACU to get surgery. It's a visual plan for what we're going to have, a plan which is closing the unit, hire more staff, new protocols to be written or added to the protocols. And the action will be having a team force to implement the change. We need HR to be involved. We need an educator to be involved. We need a quality improvement team. We need management corporate approval. We need finance allocation. And also implementing time. That's when we're gonna test our plan. If it's working, we're gonna evaluate the outcomes. This is where the checks and balances is to check if the money we are putting in is going to bring about the patient satisfaction. So enjoy it. Thank you.